Okay, good evening, ladies and gentlemen. And today is quite an easy lecture. It's how to respond, how to interpret and respond to letters from journals. And the second part is a lecture I gave to the Council of Science Editors in America on why North American or British or Australian journals should help non-native speaker authors with their manuscripts, especially in the field of medicine. Okay, so here we start off with, now these are all real actual letters from the editor. And he's saying, okay, it's been reviewed, your paper here, it's been reviewed favorably, okay, and is returned to you for minor revision. As soon as you see minor revision, you can say, great. Now, as I said yesterday, papers accepted as is almost never happens. Dr. Abrams said the same thing. I think Dr. Rabbit said the same thing. It almost never happens. The best you can get is a minor revision. But even the minor revisions, okay? This is still the American Journal of Hypertension. We will evaluate the manuscript again after these changes have been made. So they're telling you, okay, just minor revisions, but you have to be careful. You have to make the changes. But here, again, they're saying, to keep to our publication schedule. Now, this is an important term because what it means is they have already scheduled your paper to appear in the January issue or the February issue. It's already on the way, right? So they want you to reply within the next 2 weeks. Now, these are minor revisions. The other day, one person asked me how long should they take to reply. Well, if it's a major revision, 4 weeks. If it requires an extra experiment, maybe longer, but if it's a minor revision, 2 weeks. And then they're maybe a little bit of a threatening. They're saying, if you take more than 60 days, that will cause us trouble, and we'll review it from the start again. It will be considered a new paper. And they go on, and the comments they have is that the discussion is diffuse and could be shortened. There are some sentences which are difficult to understand. I have been impressed by the short discussions of the papers at Bundang Hospital that I have edited. Most of the discussions have been very reasonable length, 2-3 pages. As Dr. Abrams said yesterday, they do not want 4, 5, 6, 7, 8 pages of discussion. I have had the opposite experience. This was a doctor from internal medicine at Tokyo Medical University, and it was his first paper in English, and it was 9 pages, okay, 9 pages. 7 pages were the introduction. I told them, no, go away, you know. Come back with a 1-page introduction, 2-3-page discussion, and sufficient materials and methods to reproduce. And the guidelines for revised manuscripts. Now, here it's the same journal. They're saying now the revised manuscripts must be sent in triplicate. But why, I don't know. Probably they're sending one to their proofreader, one to the associate editor, and one to the printer. And they also want a different number of copies if changes have been made to the original figures. If you haven't changed the original figures, you don't need to send these. Okay? So this is one occasion when the guidelines for the revised manuscripts are a little different from the original instructions to authors. So you have to look at the instructions to authors, yes, but you also must follow the letter from the editor very carefully. Again, they're saying a list of responses to the comments must be included with page numbers indicating where the changes were made. Well, that's common sense. Again, and they're saying make sure, and they're giving you a checklist including a title page with authors' names, degrees, affiliations, short running title, exact postal address, telephone number, fax number if available. An abstract of 1 page or left, appropriate or less, appropriate headings for each section, legends to all figures on a separate page, and make sure that the references are in the style of the American Journal of Hypertension, AJH. Okay? Now, here they're giving you initial shock, but then they are giving you an escape route, okay? And you read this, I regret, I regret, no. To inform you that the paper is not acceptable for publication. And that gives you a very negative feeling based on the recommendations of 2 reviewers and an associate editor. This is the American Journal of Pathology. However, they say the editors would consider for review a new manuscript incorporating the following. Okay, well, what do they want? Is it a very serious change or what? Describe the sample sizes and criteria for histologic diagnosis. Well, that's pretty easy. Number of subjects, histologic criteria. Consider that P53 mutations might contribute to genomic instability. Okay, that should be okay. Provide more details about the staining protocols. Okay. Put in the references suggested by both reviewers and substitute figure 2. So not too bad. So it's quite easy. So at the beginning, they came out with, I regret to inform you, blah, blah, blah. But more journals are becoming a little bit more friendly in the letters to the auditor, to the author, but the editor is a little more direct in indicating, like I said yesterday, it does not have sufficient priority, or we're receiving a large number of papers and it did not have sufficient importance. As soon as you see priority, importance, you know that it's a go away signal. Especially if they suggest that you go to another journal. That really is a sign for, go away. Even if we give you comments on your paper, that does not mean we're going to accept it rewritten. Here you have, thank you for submitting to the British Journal of Cancer. I enclose a salient report. There's substantial criticism based largely on the size of the study. So they're saying that you did not have enough human subjects or animals, whatever. The size of the study wasn't enough. So I must decline your manuscript. At the same time, he's saying, however, if you have got new data, more data, if the sample size is increased, which confirm your results and are substantial in number, I would be happy to reconsider this decision. So I'm willing to reconsider if your sample size is increased. Otherwise, it's no. Peer and editorial review have been completed. I regret to inform you, not good, that compared with other manuscripts, currently under consideration, its rank, when you see this, its rank was not sufficient, or its priority was not sufficient. That is a signal meaning no, okay? To be accepted for publication in Cancer. No matter how much you rewrite it, its rank, it was not considered to have enough new information. And they're saying that they've given comments from the review, and we enclose them, and maybe of help should you wish to submit the manuscript to another journal. So go away, please. Okay? Here's circulation. And they're using the word priority, right? It's been evaluated by 3 referees, comments enclosed. I'm sorry to report its priority, its rank, its importance is not sufficiently high for publication. Again, this is a definite no signal. And then they're very polite, this journal. They go on, they say, we know you will be disappointed by our decision. We recognize the careful nature of your work. However, we have reached this decision. 3 reviewers' comments are included with the hope that they will be helpful to you. We are reviewing a large number of manuscripts, and only those receiving the highest priority can be accepted. So yours did not have enough priority. However, I hope you will send us additional manuscripts, not this one, but other manuscripts that you may have. So a letter like this means that they're generally interested in your work, but this particular paper just did not seem to have enough value for their readers, okay? And remember, these publishers, they're doing it for a business. So they cannot publish substandard work. This is laboratory investigation. Paper was well written, findings well documented, but the editors think that the data is, just like my mistake yesterday, the data are too premature. It's a very common mistake among native speakers. The data are too premature to publish in the journal. There is no evidence that the peptides are synthesized by the tumor cells, and no data on the resected tissue are presented. So to the extent of the evidence that you have shown us, there's no reason for us to publish your paper. And they go on to say, at this stage, these 2 markers are not, their value is not established enough to merit publication. We suggest that you consider submitting the paper to a more specialized tumor marker journal. So again, they're talking about the readership. A journal that is concerned mainly with tumor markers might be more interested in it than laboratory investigation, which is a more general preclinical lab benchwork journal. Now, those are the kind of comments you get from the journal. Basically, that covers the range of them, from accepted with minor revisions to no with comments, and why we don't think it's enough rank or priority or importance. Now, you can disagree with a reviewer, okay? There's nothing wrong with disagreeing with a reviewer, as long as you do it politely. And as I said, remember that most reviewers, when they do the review, they're tired. They really are. It's 10 o'clock, 11 o'clock, they've had a long day, and they're doing this as volunteer work. And sometimes they make very obvious mistakes. This guy's saying, if there were atypical changes, it would be really interesting to know their relationship with mutation. And then the author says, as described, we did not use any atypical foci. So if what he doesn't say is, look, if you had looked on page such and such, line such and such, you would have seen that we did not use, but you don't get angry. You just do it very gently, okay? Because the reviewer is trying hard to improve your paper for free. So that's a nice way of, oh, sorry, excuse me. And this is one technique that I use. When you cannot adopt one reviewer's suggestion, you use another reviewer's comment to negate, to contradict the first reviewer. So this reviewer says, I think the term pancreata is preferred over pancreas. Okay, so if you take this reviewer's comment, then you change all pancreas to pancreata. But what the author did was he used another reviewer's comment to go against the first reviewer's suggestion. And he says, another reviewer also pointed out this, and he recommended to place all pancreata with pancreas. I've rewritten as pancreases throughout the manuscript. So he's taken a third way, okay? But it gives some justification. He's not just saying, no, I'm going to use pancreases. You can say that another reviewer came up with a different suggestion, and I'm choosing a third way, okay? Now, this is a common mistake. It's one sometimes I make. You say sufficient or not sufficient, but you fail to say sufficient for what? So you're going to adopt the comment, you're going to accept the comment, and indicate the location, okay? And this is the same for the word enough, okay? People often use the word, we had enough samples. Well, enough for what? What's your definition of enough or sufficient? It means sufficient number of foci and cases analyzed in order to study and compare the mutational sequence between MCH and carcinoma in the same patient, revised on page 6, line 2. So you're accepting the comment, and you're giving the definition as required, and you're saying exactly where it is going in the new document. And another thing I've been impressed about, most of the authors from Bundang Hospital are very polite in their replies to reviewers. And that's a good thing. You should try to change the words a little bit, not just, thank you for your excellent comment, thank you for your excellent comment, thank you for your excellent comment. You know, change it a little bit, like, thank you for your insightful contribution, or we are grateful for you pointing this out to us, you know, and then thank you for your helpful comment. But or your cogent is a good word, C-O-G-E-N-T. Cogent means very thoughtful comment, okay? We appreciate your cogent comment. Yeah. Right, so given the focus on MUC gene expression sialyl mucin, the author should inform the reader that the gastric mucin 45M1 is MUC5AC and 19.9 is sialylated, non-acetylated or small intestinal type Lewis A. These points help to increase overall coherence and integration in a somewhat complex area. And so the reviewer has put some work into thinking how he can make your text more readable and more understandable. So we appreciate your advice. As you pointed out, this is this, and this is this. So we added these points to the materials and methods and changed them to MUC5AC and Silo LEA throughout the paper. So that's, you're indicating the pages and the lines, etc., which is a good thing. Although today with track changes, there's less need for that. But I still usually tend to say, because if you have a lot of track changes, it can be difficult for the editor-in-chief to find exactly what you're referring to. And as I have said before, if the editor-in-chief can avoid resending the paper for another review to the reviewers, he will be happy. And then you will be accepted quicker, and the reviewers have less work to do, and it's a win-win situation. Again, there's no mention in the methods of what Con A3 stains or how it was stained. Now, to the author, this might be very obvious. But as I mentioned to one person last week who was having his paper edited, I said, you should aim at a well-educated high school or first or second year university student. That's the kind of level you should be writing at, because you want to get as broad understanding as possible. You don't want to just hit, if these are all the experts in the world on a given field in the room, I don't want to just hit these 7 people. I want to hit all of you, and maybe some extra people who may become interested in my work. So have it broadly understandable. Thank you for your advice. And then you're giving the references, what you took it from, and we added these points in the materials and methods. Now, in the uniform recommendations, they say that if the materials and methods, if the methods are generally accepted methods, you can just use a reference according to the method of so-and-so. If you've changed it a little according to a modification of the method of so-and-so, briefly, in order to, you give the reason why you modified it. And please avoid the term, the modified method of Smith, because that has 2 meanings in English. It means the method of Smith that we modified, and we're not telling you how we modified it, or the method that Smith modified. It can be either. And I have no way of knowing. But if you say, according to the method of Smith, which we modified in order to stain for Nantuka, and then say briefly, we added such and such kind of staining to the procedure. And how a comment can make a revised original look better. And here the reviewer is saying, okay, the authors mentioned that there were 10 complications, okay, that could have influenced the infection at the site. We should know what these complications were in order to have a better understanding of the risk factors and what impact the risk factors have on the future of these 17 re-implants. So the authors go back and they look at the 10 complications, and then they realize that because of the reviewer's comment, they find out that there were 10 complications, but following our reappraisal, based on your comment, we realized of these 10, there were 4 cases of cardiac disease, 1 of renal disease, so these would not be directly related to liability for infection. So it makes our figures look better through the comment of the reviewer. Therefore, we reduced the figure of 10 complications to 5, and we specified in the text that there was 1 case of rheumatoid arthritis and 4 of diabetes mellitus. and how the valid reviewer's comment induced a necessary hedging statement. Hedging, those of you who follow finance have probably heard the term hedge fund. A hedge fund is a fund that you use just in case something goes wrong. That's basically. So I can say, it's going to rain tomorrow. Now, that's a statement. If I say, the weather forecast says it's going to rain tomorrow, that's a hedging statement. I'm not saying it. The weather forecast is saying it. Or she tells me that it's probably going to rain tomorrow. Well, she says one hedging, probably second hedging. Okay? So these are important to use instead of sounding too arrogant. Like, this is the first study on. It's better to say there's little other. There are a few other reports on this subject, or we could find an extensive search of the literature failed to allow us to retrieve any other reports on this subject. That's basically, you're saying we're the first, but you're just saying that we looked for it, we couldn't find it. The authors also state on the same page that stable reductions were obtained in all cases. Since head and neck length are not easily adjustable with spacers, how did they obtain stable reductions? What tricks did they employ? Thank you for pointing this out. On review, we felt that our statement that stable reductions were obtained in all cases might be a little too strong. So then they put in the hedging statement. Therefore, we put in the hedging term, the qualifying term, relatively. We did not imply any particular tricks or special techniques, but there was no case of instability or displacement. So you should always be careful about sounding too positive. And again, here you have a simple comment that results in increased understanding of the revised manuscript. The authors don't mention whether scanning was involved in their decision-making technique. We relied only on plain X-ray films, not on any scanning techniques in our decision-making process. And we have included that statement at the end of the first paragraph on patients and methods. And so that's an important point. I mean, it tells the reader that they reached their decisions without any scanning. And it takes up one line. So it's worth it in terms of information per area of the paper. A simple comment resulting in an important addition: were suppressive antibiotics used at all after reimplantation? And if so, for how long? Did the type of organism play any role in their decision-making process? Thank you for pointing out this important point. We explained that intravenous antibodies were given for 1 week, following which orally administered antibiotics were given until CRP rates became normalized. Furthermore, our decision-making process to select the antibiotic agent was based on the result of sensitivity tests on cultured materials obtained from all cases using materials obtained intraoperatively. So this is a very important point that had not been included in the original paper. And because of the very simple comment, they were able to make this important addition to the paper. And as it says here, don't just show your best stuff. Don't just show the good stuff. Lastly, the authors show a single case of a spacer in place. It is an idealized case, a failed bipolar with good acetabulum and fairly normal femoral bone stock. I would like to see an example of the worst case, a poor acetabular bone stock, type 3 canal, so that we can judge how these spacers work in the worst case scenario. So the reviewer is saying, I'm not interested only in your best case, but also your worst case. We added our worst case, type 3, which appears as figure 2b in the manuscript. Lastly, although it was not pointed out, when we revised our paper one more time, we found out that the breakdown of cases according to the bone loss evaluation was slightly incorrect, and we've made the changes in the third paragraph of patients and methods. So again, this came out partly because of this simple comment of saying, well, what was your worst case? And this is a cover letter introducing responses to the reviewer's comments. Thank you very much for your comment regarding our paper. We're very happy because of your very careful consideration and your correction of this manuscript. We hope that you will find this resubmitted manuscript suitable for publication in gastrointestinal endoscopy. Okay? So this could be in the letter to the editor, thanking him for all the comments made by the reviewers. And here, again, a cover letter introducing responses to the reviewers' comments. According to your comments, I'm enclosing herewith a revised manuscript. We changed several points as follows. It should be noted that this study was performed using only one type of echoendoscope with a relatively large channel. These results could differ depending on the size of the channel. So they're saying that, okay, you only used one kind of endoscope with one kind of instrumentation channel. How about with others? Since we agreed with your opinion, we did an additional examination using a diagnostic US scope, Olympus with a 2.8 channel, as opposed to a 3.7 channel, right? So then he changed and he did it with a 2.8 millimeter channel. Okay, now here is a case where it seems that the reviewer didn't really understand the paper. This was a paper that I had edited, and they had done some experimental work on the insertion path using a machine to insert the needle through the endoscope. And for a reviewer who should understand endoscopy, who doesn't understand insertion path, is just very strange. Okay? Please explain in more detail the source of resistance to the passage of the needle. Well, anything you put the needle into is a source of resistance. If I put it into the desk, it's going to be more resistant than into the chair. It's very obvious, but you can't be rude, right? You have stated examining insertion resistance throughout the 30 millimeter insertion path, both the 22 and 25 gauge needle showed the maximum level during the initial 5 millimeters part of the insertion path. I'm not sure what the insertion path is. Well, it's the route of insertion. It cannot mean anything else. But they don't say that. They just said, okay, we rewrote it, okay? We rewrote as follows. Examining insertion resistance throughout the 30 millimeter insertion path. And they don't explain the insertion path here. It's too obvious. But they've changed the sentence. Both these needles showed maximum levels during the initial 55 millimeter part of the insertion path, and thereafter the insertion resistance was stable. It's basically saying the same thing. All you're doing is you're changing the sentence just to basically satisfy the ego of the reviewer. You're not saying you made a ridiculous comment. And here you're thanking a reviewer for a very important, necessary adjustment. In figure 31, the reviewer says, is it correct to state mean pressure N to maximum pressure N? Thank you for pointing this out. We changed mean pressure N to maximum pressure N, which makes a big difference. Okay, and this is a case of jargon. Do you know what jargon is? Jargon is like sort of language you use among your friends, but people outside wouldn't understand. Maybe even people in different departments wouldn't understand. Like in our department of surgery, if we say we did an MB, that means a needle biopsy, but somebody in dermatology might not understand what an MB is. And here the author used the term long and short position. And this is, I had told him this, and he ignored me. What he meant by long means with the endoscope straight out. Okay, that's longer. And when it's curled back, it's shorter. Okay. In the outpatient department, okay, put it long, make it short. Okay, that's fine. But for a written paper, you can't use slang, and that's basically what jargon is. As this could be confused with the use of this term, consider it straight and angulated, which eventually he did. We agree with you, and we changed long and short positions to straight and angulated. Although in many endoscopy papers today, you'll see long and straight, long and short. But I really do not agree with it, because you have different lengths of endoscopes. So if you've got a short endoscope, you've got a short in length endoscope. Okay, and this again is this experiment where they're trying to show the resistance to insertion, and the reviewer is saying, how did you choose the speed of 5 millimeters per minute, 500 millimeters per minute, okay? That's sort of half a centimeter a minute. This appears somewhat slow compared to the usual rate of needle puncture and cytology acquisition. So he's saying this is very different from the clinical situation. And the authors reply, well, we agree with you, yes, but this was a bench simulator, and the only machine that we could use that had stability and reproducibility, this was its maximum speed. So if you don't like it, I'm sorry, this is the best we could do. We don't have another machine that can go faster. Improvement in statistical reporting. While the results from Table 1 are self-explanatory, is there a statistical test, Pearson should be capital, that could be done that could summarize the correlation between the endosonographer's subjective results and the results from the resistance studies? Yes, there was a statistical test, Pearson's correlation. There were strong correlations between the subjective results and the results from resistance studies, and we added these to the results. So the overall statistical reporting and the overall meaning and value of the paper increases due to the reviewer's comments. Okay, this is a partial response. This is an excellent overview of transpapillary gallbladder drainage. The only drawback is the lack of more clinical information to guide therapy. Comments follow. Please explain what Chilaiditi syndrome is, as most of our readers will not know, including this reviewer. So the author has decided not to explain this part. He just goes directly to this part. explained Chilaiditi syndrome in the patient methods as follows, that a rare condition which occurs when there is a loop of colon between the diaphragm and the liver. So he's only answered half, the convenient half, but this is one way out of answering a question that you cannot completely respond to, or that responding to would take too much time and space. Lack of important information. Okay, you have outlined the management of the nasocystic drain as to the type, volume, and frequency of irrigation. They just said that they had the nasocystic drain in place, and that was all the information they gave. But according to your suggestion, we described about the nasocystic drain in detail. And then they put all of this in. After the ETGD procedure, if cloudy fluid, pus, or blood was aspirated, the gallbladder was rinsed with 100 to 200 millimeters saline every day using a 10 millimeter syringe until completely clear fluid was obtained in consecutive days. Now that is very important. That goes in the methods. Furthermore, we rewrote the sentence and added as follows. The mean time required, the mean time of required days to obtain clear gallbladder contents was 2.6 days, range 1 to 7 days in the results. So you're giving a much more informative paper to the reader now because of the reviewer's comments. Was the tube left in place until surgery if the patient had the operation on the same admission? Yes, I added the drainage tube was left in place until surgery if the patient had the operation on the same admission in the results. Actually, you should put page number and line number here too. Okay, this is an important comment that is easily answered, but it should have been in the first draft. Although empirically, one assumes the beneficial outcome relates to drainage, the use of antibiotics alone, of course, may resolve the acute inflammation. This is true. Please comment and indicate whether some of these cases were done after failure of antibiotic treatment and the duration of that therapy before drainage was carried out. So they want more detail of the interrelationship between inflammation and drainage and how long the drainage took. Thank you very much for your important comment. In this study, endoscopic transpapillary gallbladder drainage was performed only if the patients did not improve within 24 hours of conservative management by treatment with intravenous antibiotics. So this is important. They give antibiotics for 24 hours, and if there's no improvement, then they put in the gallbladder drainage. We added the above inclusion criterion to the patients and methods. Okay, if you've got local legal problems concerning doses, you cannot fight back, just take the situation. Some of these subjects were treated for 12 weeks with relatively low doses of donepezil compared to America. Okay, and as mentioned above, although the dose of donepezil may be low by Western standards, by Japanese standards, it is the maximum permissible. And it's in answering these kind of questions that's why it's important that, the way I showed you yesterday, that there should be support for authors whose native language is not English, especially if it's not an Indo-European language. And you can discuss, well, why did you not give more than donepezil? Well, we gave the maximum we could. We couldn't give more legally. Okay. And usually people are willing to accept that. Copy editor level fault. Okay, this is my mistake. We're talking about consecutive series. And in this consecutive series, we did not mention that there was any AD or possible Alzheimer. And just last week I was asked, what does consecutive mean? Consecutive means in a row. But you can say excluding patients suspected of or who had a diagnosis of Alzheimer's disease. And we have removed the word consecutive, as that allows a more accurate reflection of the actual clinical situation. Basically, this means we were wrong. We should have put in, and so you be very careful of the word consecutive, because if you say 248 consecutive patients, you mean 248 patients beginning from case 1, without exception to 248. So if you're doing a series of non-squamous cell lung cancer, and you say we treated 500 consecutive cases of adenocarcinoma. Well, wait a minute. What do you mean by consecutive? Well, among non-small cell, you've got alveolobronchial, you've got other subtypes, et cetera, et cetera. So you're not talking about consecutive cases. Consecutive cases that met our enrollment criteria. Okay? So consecutive is a little bit of a dangerous word. And as I said, this was my mistake. And there's a significant disparity between the percent of cases between donepezil for Alzheimer's, diffuse Lewy bodies, and vascular dementia, respectively. There appears to be selection bias. You've got 84% Alzheimer's, 77% diffuse Lewy bodies, and 35% vascular. So there seems to have been some selection bias. If so, what was the bias? What was the reason for more than double Alzheimer's getting donepezil than vascular dementia? Then how can the group differences be explained if it's not a bias, right? And then they say, thank you for pointing this out. We have included a statement about the possibility of a selection bias being present. So you're admitting it's possible to have selection bias. But the only explanation for this is that under the insurance system, under the Japanese health insurance system, there is no recognition of donepezil being prescribed for a vascular dementia per se. So if you have a patient diagnosed only with VAD, you cannot give that patient donepezil. If you've got VAD plus suspected Alzheimer, that's possible. This may have been why the individual attending physicians tended to use it less. Remember, in America, different insurance companies have got different policies. There are very few national policies or even state policies about prescription of drugs. And so they don't have that in their mind when they are reading papers from the UK, from Korea, from Japan, where there are national guidelines of what you can do, what you cannot do. Why was Spearmans rank correlation used instead of the parametric equivalent? Even when the reviewer is wrong, be polite. And the answer is because MMSE, the mini mental state examination, is a non-parametric system. So that's why they use Spearman's rank and not Pearson's. Adding a requested reference on statistical methods should include a reference to the statistical literature describing and validating this method of analysis. Okay, this is a kind of comment that many papers, I think, from Korea and also Japan get, because many of the authors do their own statistics, and it can be very tough. Whereas if you have a biased statistician, you can stick in the authors and say, the biostatistics were done by Dr. ABC, then it's a lot easier. So we added 2 references for the ROC analysis in this section of materials and methods. And again, here the referee is asking for elimination of a data subset, and unless there are data from the literature indicating that the 5 additional missense mutations are truly without functional significance, they should be eliminated from the wild-type group in Figure 3 and the data reanalyzed. So the authors agreed with that. We excluded these cases and reanalyzed, and almost the same results were fortunately obtained, as mentioned in page 17, paragraph 2, and page 18, paragraph 3. According to these changes, we rewrote Table 2 and Figures 3, 4, 5. Thank you for your excellent suggestions again. Now here you've got an impossible demand, okay? An impossible demand. The correlations of FDX, RG, and special are fairly poor, even on the samples on which the discriminator was developed. Okay, well, okay, so far so good. It would have been helpful to see in this classifier could have performed well on a completely different set of tumors. Well, I can't now go back and get a totally different group of tumors and do the same study. It's going to take me another 2 years. So, and sometimes the reviewers are just saying, oh, I wonder if, and they're not really criticizing, they're just sort of tossing out an idea, thinking aloud. I agree with you. Okay? We added a sentence to mention the necessity of a prospective study to confirm our results. So we just stuck in something at the end saying our limitations include the fact that we did not look at a totally different group of tumors or whatever, or you put it in the discussion somewhere. But by saying, I agree with you, you're diffusing the situation, okay? Okay, this is something that really, really annoys me. When I've edited a paper carefully and it's sent off and it comes back, they just see all the Japanese names and the first comment is, oh, get an English person to look at it. So, English should be checked by an expert in English. So we answer with a slight degree of resistance. We reconsulted our English reviewer. That means we had already consulted him. Don't you understand? And we reconsulted him, but we review your review and positive suggestions for our manuscript. Thank you very much. Ta-da, ta-da. Music playing softly in the background, you know. But at the end, basically, the reviewers really have tried to improve your paper, usually. I mean, comments sometimes may be very sharp, maybe very critical. But basically, they're trying to improve the science. And here's a closing term you can use. Thank you for pointing out our mistakes. These points have been rewritten into proper sentences. We think your comments have allowed us to significantly improve our paper. Thank you. Let me thank you once again and for having helped us improve